This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is amongst the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at SCZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar role of Oseltamivir in flu management, we have Dr. Pramod Zog sir as moderator and Dr. Sanjay Nathu and Dr. Anil as our speaker. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Welcome, Dr. Pramod Zog. Dr. Sanjay Nathu is MD, ADNB, MN, AMS, FACEE, PM, currently Professor and Head of the Department Pediatrics from March 22 till date at Srimati Kashibai Navale Medical College and General Hospital, Pune. Sir is Consultant Pediatrician, Shashwat Hospital, Kothurud, Pune. Areas of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Sir has been President IIP Pune Branch 2021 and is member of Pediatric COVID Task Force, Pune Division. Welcome, Dr. Sanjay. Dr. Anil is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care, DAA Diploma in Allergy and Asthma. Sir is Lead Consultant, Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bangalore. Welcome, Dr. Anil. And with this brief introduction, I hand over the session to Dr. Pramod sir. Over to you, sir.
Thank you. Thank you. We will start with the discussion.
Yes, sir.
Yeah. Just 1 minute. Okay. Are you able to see the slides?
Yeah. Not as yet, sir. Yeah, completely.
Okay. Yeah. Thank you. Thank you. Thank you. So, good afternoon, friends. We are going to discuss a very important topic related to the use of Oseltamivir in flu management. And this topic is of great relevance because influenza is an illness which creates a lot of morbidity and mortality. And I was just discussing with one of my friends from US, and he said that in the year 2024 and 2025, maximum influenza activity was seen, and even the hospitalization, which was reported by a mechanism called as flu serve net, which reached its highest in this particular period during 2024-25. And in August 2025, CDC reported 278 influenza associated pediatric deaths, and that's quite a significant number. So it is necessary that we know a lot about influenza and use of oseltamivir early in the course of this illness. You can see that I have put up my name in the fashion as influenza viruses are put up, that is called as nomenclature, which includes the place of origin and the year of origin. And all of us are aware that monsoon is the period when activity of influenza is at its peak, though influenza continues to be present in the atmosphere all during the year. And in some parts of our country, particularly Kashmir and Kanyakumari, the activity is seen during November and December. And we all know that viral infections definitely have increased over the past. And Sanjay, can you just think about some possible reasons as to why viral infections are on rise?
Yes, sir. So, good evening, everyone. Yes, a very important issue. And last several years now, especially since the post-COVID era, we have been seeing that the number of viral infections have gone up in our practice, may it be OPD and even IPD. And I can think of a couple of reasons at least. One of them could be the COVID pandemic itself, when all the kids were locked up at home, not going to schools, not mixing with other kids, and when they were not exposed to very many viral infections at all. As a result, the usual phase of developing of immunity after exposure, which happens in the kids in the early age group, did not occur. And these kids have sort of an immunity debt, and they have never faced these viruses which they are facing right now and developing infections which are a little more severe and more common. On top of that, we have so many bacterial vaccines nowadays, or vaccines which work against many bacteria. So the common bacteria which used to bring patients to the pediatric clinics, for example, the H. influenzae, the pneumococci, they are covered now with very good vaccines, and as a result, the infections because of these bacteria have gone down over last few years. So as a result, more viral infections, and most of our practice now is basically due to the viral infections.
Right. And if you agree with me, the pneumonias related to RSV or pneumonias related to influenza, they are the ones which are showing predominance in this particular area. In the post-COVID period, we are also witnessing that even the older children are getting affected. And as you rightly said, after COVID, we had upsurge of various viral problems like hand-foot-mouth disease, RSV. At particular time I remember adenovirus at its peak, and in some areas where measles immunization was on the lower side, even measles was reported to a larger extent. So one should be really aware of different viral infections in the community. And I will tell you about this 3-year-old boy who came for fever, cough, and cold, and progressive breathlessness over 3 days. He was tachypneic with saturation of 85% in the room air, and the X-ray picture was suggestive of acute respiratory distress syndrome. He was admitted to the PICU, was ventilated, and he received oseltamivir along with suppurative therapy. And H3N2 was positive from his throat swab. He was ventilated for 3 days, and then he was discharged and he was all right. So the question which comes up over here is that when a previously healthy child presents with cough, cold, and fever, particularly in the season of influenza, and progresses over 3 days, whether the treating clinician can prevent this particular progression by using oseltamivir early in the course of illness, so that all these problems like getting into the PICU and getting ventilated and all can be avoided. So there are certain important points which I would say these are points with confusion, because they are the confusing points in relation to flu. And the points are whether when a child comes to us, we have to decide whether it appears to be bacterial or viral. We all know that viruses affect almost all the systems of the body. Even at one particular moment, when viral infections occur, the child can have respiratory manifestations as well as GI manifestations, while bacterial infections are generally localized. So if a child gets bacterial tonsillitis, then the same child won't get pneumonia because of the bacterium at that time. So in general, they are localized. In case if it's viral, what is the virus, whether it's a rhinovirus, adenovirus, or influenza? And if it is influenza, whether this is H1N1 or H3N2, and whether I should start oseltamivir upfront. We are going to discuss most of these issues in the next discussion. And we all should know that, as I said in the beginning, there are quite a few healthcare related challenges in monsoon. And in general, we group all those under influenza like illnesses. And influenza as a disease will be responsible for systemic presentation in the form of headache, muscle pain, weakness, high fever. And that's why I always say that influenza is the father of all those influenza like illnesses. In general, they present with cold, cough, and fever, but then the severity differs. And the overall mortality and the morbidity related to influenza is rising alarmingly in India. One should know about the three types of influenza viruses: influenza A, influenza B, and influenza C. And I always say that let us know the KYC, just as in the bank we have know your customer. So we must know one of these, enemies like the naughty influenza. I call it naughty because it changes its structure every year. And influenza A causes frequent epidemics due to the minor antigenic variation in the amino acid sequence in the glycoproteins which are present on the outer side. And it also is responsible for periodic pandemics. This influenza A grows in birds, animals, human beings, and when the influenza A virus from a bird mixes with influenza A virus from the human beings in some third party like a pig, then there is a novel influenza virus which occasionally produces pandemics. Okay, so the pig acts as a mixing vessel and totally new virus comes in circulation. And this is how the 2009 pandemic was known as swine flu pandemic. Okay, now that particular virus continues to circulate at a lesser frequency in the atmosphere, but people still have like that swine flu at the back of mind, though the panorama of all those viruses has definitely changed. Okay, influenza B infects only the human beings. It doesn't infect the animals or the birds, and it produces only local epidemics. One should also know a bit about hemagglutinin and neuraminidase. These are the two glycoproteins on the outer side of the influenza virus. Hemagglutinin is responsible to allow the virus to get attached to the respiratory epithelial cell, and the RNA of the virus gets access into the respiratory epithelial cell after the attachment is facilitated by this hemagglutinin. Once the RNA from the virus enters inside, it dictates the DNA of the respiratory epithelial cell to produce its own copies. And then so many RNAs are produced, which are known as virions. And neuraminidase helps to separate all these copies, just like a molecular scissors. And then these virions, they get out of the respiratory epithelial cell to infect other respiratory epithelial cell. And oseltamivir blocks this particular process. So we know that oseltamivir is a neuraminidase inhibitor, so that those virions do not get an access to get out of the cell and infect other respiratory epithelial cell. This is extremely important. And as I was trying to tell you about influenza A producing those global pandemics, the first one was called as Spanish flu. That was 1918, 1919, when oseltamivir obviously was not there. And at that time, the only therapy available was oxygen, hydration, and bed rest and extra fluids. Quite a few people all over the world, they died. Of course, the term Spanish flu was a misnomer because it was seen in many parts of the world, US and Europe and others. There were another pandemics in 1957, 1968, 2009, and all of these were related to the influenza A virus. Okay, Dr. Anil, just wanted to know whether, what are the recent updates in the epidemiology and the circulating strains of influenza viruses affecting the pediatric population in India?
Yes, sir. Good evening. Thank you, sir. So, like sir has discussed already, sir has given us the KYC, told us the types of viruses is influenza A, influenza B, and influenza C. And locally, what we have been seeing, I think all over India and even in Bangalore, I practice in Bangalore. So we have been getting lots of cases of influenza A. Particularly in influenza A, the subtype we are getting is H3N2 subtype. Also, we did get few cases of H1N1. See, this H1N1 virus came up in 2009. Probably 2009, it was a very new virus arising out of an antigenic shift. There was a sudden shift in these hemagglutinin and the neuraminidase glycoproteins. So this was a new novel virus in 2009, which came up, which was a pandemic. Now it has become a local epidemic kind of a virus. So we saw a lot more H3N2 this time, few cases of H1N1 and fewer lesser cases of the type B lineage, that is a Victoria lineage we saw. So when we ask for a flu panel, usually they'll give us whether it is influenza A, influenza B, and the subtype also, whether it is H3N2 or H1N1.
Thank you. And in this 2024-25 season, both H1N1 and H3N2 subtypes, they have circulated nearly equally as per CDC. And interestingly, no influenza B or that Yamagata lineage viruses were detected in that particular season in the US. Probably, that was the reason why the forthcoming batches of influenza vaccine are likely to be trivalent and may not contain the influenza B type into that. So this particular flu virus basically is a virus which is transmitted very, very rapidly. And the R0, that is the ability of the virus, one person infecting others for this virus is quite high. Though it's highest for respiratory syncytial virus, flu virus and COVID virus, they do have high transmissibility, and they are mainly spread by droplets when a person coughs or sneezes or talks, and these droplets land in the mouth or the nose of the people who are nearby, and then from the nose they go down very rapidly, and development of pneumonia is very, very fast. So Dr. Sanjay, will you like to tell our listeners about different clinical scenarios with which influenza presents in the pediatric population?
Yes, sir. So the commonest manifestations which we see in our day-to-day practice is the usual influenza-like illness, which comes with fever, cough, cold, rhinorrhea, sore throat, uh, ill-looking child malaise. So, and the child may also have body ache, muscle pains. Some headache is also common, and these type of patients form the majority of our OPD in this influenza season. Formed the majority of our OPD in the last 2-3 months, in short. And most of these patients tend to recover also quite early in 3, 4, 5 days if we give the supportive treatment. However, some unusual presentations are also commonly seen, and this year we also got few patients presenting with gastroenteritis, which is not unusual for a patient of influenza, because as you already mentioned, influenza usual viral illnesses usually affect the whole all systems, and hence along with the respiratory system, the GI is also commonly involved in this influenza. We also had a number of patients presenting with neurological manifestations. For example, some patients came with febrile status, a couple of patients with encephalopathy, and unusual presentations like myocarditis were also seen by some of our friends, though personally I did not see any case of myocarditis.
Okay. Now, if at all we have a look at all those influenza-like illnesses or H1N1 or severe acute respiratory infections or COVID-19, there are differences to some extent in these different illnesses. However, it's very difficult to differentiate one from other. And that's why the nasopharyngeal swabs, they come to our rescue. Just to give an example, during COVID times, we remember we had loss of smell and loss of taste in those patients. And about influenza, we just said that the child can have severe headache and prostration and muscle pain, to the extent that even an older child many times is lifted by his father and brought to the clinic. So basically, influenza is behaving like a systemic illness, and all these illnesses, they will produce initially presentation related to the virus itself, and in the course they may produce some immune problems, and those secondary problems which come up after 4, 5, 6, 7 days, which we put it as the cytokine storm. So that is the immunological problem which comes up in some of these viruses, and we have witnessed this during COVID-19 to a great extent. And Dr. Anil, now that you are closely associated with the intensive care settings, uh, I would like you to tell our listeners, and also our listeners in turn can inform their parents about the emergency warning signs of flu, as to when a child should be brought to the clinic after in case if they find some of these symptoms.
Right, sir. These emergency warning signs, we also do call them as the red flag signs. These are the signs which I think we should sensitize the parents to watch out for and look out for in their children. As we know, this can be very mildly sick. That's a category A, B, and C, which we will discuss later on. So whether it in category A or B, we need to keep watching for these red flag signs, occurrence of any of these. So the most commonest thing what the parents can pick up is how active the child is in the interfebrile period, whether the child is active, how good is the oral intake, whether the child is able to take any kind of oral intake or kind of refusing to take. Other thing that they need to watch out for is the CNS or the neurology of the child, whether the child is active, alert, playful, or the whether the child is becoming drowsy, lethargic, or becoming inarousable. These kind of things are the immediate things. Also, the general signs like For the respiratory system, they should watch out for any fast breathing that the child develops, any chest retractions the child develops, any febrile seizures, any kind of poor urine output, cyanosis, cold, clammy peripheries. These are the general red flag signs that they should watch out for. And if any of these are reported, we should always sensitize the parent to get back to us immediately.
That's very important. And the respiratory rate is something which, as all of us know, WHO has used for classification of pneumonias. So the receptionist or the assistants who are in our OPDs can very well train the parents to count the respiratory rate, so that when they go back to the house, at least they can keep a watch on the respiratory rate, so that if there is tachypnea, then the parents can report back, and complications related to the respiratory system at least could be detected by the parents. And there are complications of flu, which I have just put them beginning with the alphabet A, which include acute respiratory infections in the form of pneumonia, and ARDS, that is acute respiratory distress syndrome. It is important to note that influenza will produce its own viral pneumonia, that is primary viral pneumonia, and later on, these viruses usually they damage the respiratory epithelium, and that's why secondary bacterial infections with Streptococcus pneumoniae or Staphylococcus aureus, they will set in the setting where the viruses have damaged the respiratory epithelium. And remember that these pneumonias, the ones which are related to the bacteria, the secondary bacterial infection, they can be prevented by the use of pneumococcal conjugate vaccines. So it was observed that during COVID times also, those who had received pneumococcal conjugate vaccine, the mortality related to COVID was on the lower side. It means that the pneumonias basically, which are bacterial, they can definitely be prevented by using the vaccines like pneumococcal conjugate vaccine. And in addition, influenza related pneumonias also can be prevented by using influenza vaccine. So in general, this is important that our children receive both these vaccines, so that the complication rate is prevented. And in that, in case if the child again develops fast breathing, we have molecules like oseltamivir, which we can use to prevent the further progression. So prevention is very much available, and that is exactly the reason why we should use all these available modalities of therapy. Also, influenza produces a complication of acute otitis media, and influenza, as I told you, will always create a lot of prostration, weakness, high fever, and the child simply can't attend the school, leads to absenteeism from the school. As the child is at home, the parents also lose the daily wages, that is amdani, and also our colleagues many times are confused whether this is viral or bacterial, or viral complicated by bacterial, and that's why it leads to antibiotic abuse. So all these are very important points, and they almost all of them are preventable by proper use of therapy and preventive measures. Dr. Sanjay, would you like to tell us the categories of influenza, which are usually described as category A, B, and C, and then we'll go to the therapy based on these categories.
Yes, sir. So, for the purpose of management, this is very important because how the child presents decides to which category the child belongs to. So, the category A is the usual uncomplicated mild type of influenza patients which present to us commonly in our outpatient departments. So, there are children with mild fever, cough, coryza, throat pain, and there may be some amount of body ache, headache, diarrhea, and some vomiting even. And these patients usually have a self-limiting illness which lasts for about 3, 4, 5 days, and they start improving around fourth or fifth day. Usually need only supportive management. The second category is category B, which can be called as high risk or those with severe symptoms. So it is classified as B1, in which the children have severe symptoms. So the same symptoms of category A, but in a severe form. For example, very high fever, very bad throat pain, and so on. And the category B2 are those patients who may have mild symptoms, but they have some other predisposing conditions with them, or or comorbid conditions already existent, which make the likelihood of the disease becoming a little severe for them. For example, these may be small kids less than 5 years, or especially less than 2 years of age, or basically the extremes of age. So even the elderly patients, or those children who have some pre-existing other systemic illnesses. For example, a child may be an asthmatic, or he may have some kidney-related issues or a cardiac congenital heart disease, or he may be just plain obese. So all these patients would come into category B, and they would be a little more severe, you can say, as compared to category, and need to be treated that way as well. Whereas category C is the severe disease, that is the severest form of presentation, and these are the patients who usually have that what you say, the red flag signs which already were described. So they may be having respiratory difficulty, rate of breathing may be very high, they may be drowsy with shock-like features and hemoptysis, altered sensorium, poor intake, continuous vomiting, and so on. These type of patients usually cannot be managed on an outpatient basis, and they definitely need to be admitted. As far as the management is concerned, for category A, we would usually just give supportive treatment, and that consists of paracetamol, which takes care of the fever and any pains and aches which are going around, plus bed rest. Adequate hydration is very important, and isolation at home. So the child should avoid going out, going to school, and so on. This is all that is required for category, and the patient is expected to improve by around day 4, day 5. As compared to that, the category B, where you get high risk patients or those with severe symptoms. Now, these are the patients which definitely require an antiviral to be started as soon as possible in these patients. So they may or may not need IPD treatment. They can be treated on OPD basis, but early oseltamivir is very important for good results. And do we need to test the patients to start oseltamivir? If it is feasible, well and good, but it is not mandatory. So one has to remember that testing for flu or influenza is not mandatory to start oseltamivir. The last category, that is category C, we discuss are severe manifestations or patients with severe manifestations. They definitely need to be admitted and managed in the either in the PICU or in the high dependency unit. Of course, early oseltamivir is definitely to be started in these children. So earlier the better. And aggressive supportive management, sometimes with respiratory support and so on, may also be required in these patients.
So now we understand that oseltamivir is required for category B and C. So it is necessary that we know a few details about this molecule. As I already told you, it's a neuraminidase inhibitor which blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. And oseltamivir is a prodrug which is converted to the active form oseltamivir carboxylate in the liver. And this was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries. And CDC and American Academy of Pediatrics have approved this molecule. And one should also know the dosage and the recommendations of this molecule. In case of any difficulty about the dosage, there is always a product insert which is available along with the syrup or the capsules, and that's why our colleagues should not hesitate to look up these product inserts so that they every time need not remember the dose, because it's very important to know the dose exactly. So for children, in infants who are less than 1 year, the dose is 3 milligrams per kg, and the therapeutic dose is given in the fashion of twice daily. For infants, prophylaxis is not applicable. For older children, there are weight bands, and from first year onwards till the child crosses 40 kg, the dosages are in the weight bands. So up to 15 kg, it's 60 milligrams per day. Between 15 and 23, it's 90 milligrams per day. Between 23 and 40, it's 120 milligrams. And beyond 40 kg, it's 150 milligrams. For therapy, you have to divide these dosages. And for prophylaxis, you have to give the dose as once daily dose. The syrup contains 12 milligrams per ml, and you can calculate the dose accordingly. While adults require 75 milligrams twice daily for therapy and 70 milligrams once daily as a part of chemoprophylaxis. We'll be discussing a few points about chemoprophylaxis in this discussion at a later stage. Dr. Anil, we have been saying that you have to use oseltamivir early. So, how is it that this early initiation of oseltamivir influences the clinical outcome? And what is your view about early use of oseltamivir?
Yes, sir. Like we discussed already, you had nicely explained us the mechanism of how the virion enters the body, how it multiplies, and how it spreads. As we know, oseltamivir is specifically a neuraminidase inhibitor, it works like a molecular scissors. So after multiplying in a host cell, the virions will have to be released. That's how the life cycle of the virus goes. And for the release, this neuraminidase is very much essential. This our drug oseltamivir acts on this neuraminidase to prevent the release of these virions from the host cell into the system to infect the other cells. So technically also and with evidence also, it is shown that if it is used much early in the course of the disease, that is within 24 to 48 hours, if this drug is initiated, it is going to lessen the burden of these virions on the host individual. So what it does is it prevents the release of these virions. So thereby less and less number of other cells are affected. And also at the same time, the complications which arise due to multisystemic spread of these virions is prevented. So the evidence shows us that if the drug is started within 24 to 48 hours, it will lessen the duration of illness by 1 to 2 days. And the severity, as we know, once it is in category B and category C, the disease can be much more severe. So starting the drug early will definitely lessen the duration of illness. And the other question here posted is whether even on day 4, day 5, can we use it? So usually day 4, day 5 are the ones who are, if it's a self-limiting thing, usually category A, they'll start getting better by day 4 or day 5. But if they're being hospitalized or if they're coming to doctor on day 4, day 5, that means it's a progressive disease or it can become a multisystemic disease. So even in such disease scenarios, we should still go ahead and use oseltamivir and initiate it even if it is day 4 or day 5 to prevent the complication and severity of the illness.
Right. Yeah, and I perfectly agree with you because even in Pune, in Sasun hospitals, during the pandemic in 2009, oseltamivir was given to the children even after admission after 5, 6, 7 days, and the mortality was reduced substantially. That means one can use oseltamivir even in the later stage of the illness, and the benefits of empiric and the early use of oseltamivir have been proved by a lot many clinical trials, and it is known that oseltamivir treatment reduces the low respiratory tract complications related to influenza, the antibiotic use, and hospitalization. This is true for children as well as for adults. And the WHO recommendation says that empiric therapy is strongly recommended. The treatment should be started as soon as possible, and the laboratory confirmation of influenza virus infection is not necessary for initiation of therapy. We will discuss some points as to when the laboratory test is negative, what is the implication of that in the discussion of a few cases in the course of this discussion. Okay. So let us have a look at a few cases. So, Dr. Sanjay, this child was brought for fever for 3 days, cold and cough. This child was on metered dose inhalers since 4 months, and the child was well controlled with this. He received the symptomatic therapy. He was all right for a while, and then again came back with fever, cough, and cold. In between, the child was quite active. So the parents were worried, and they were questioning as to why this child is getting recurrent upper respiratory infections. And of course, we discussed earlier that these viral infections have become more frequent and they are occurring at shorter intervals. And many times there are parents who demand antibiotics, and they say that unless you give antibiotics, the child will not recover. They have their own whims and fancies, and certain things which they have heard from here and there. So when such parents come to you, how would you counsel these parents about the approach to such a child?
Yes, sir, you're absolutely right. So last 2, 3 months, we have been flooded with such type of patients who come back to us repeatedly. One infection followed getting better, immediately coming up with another viral infections and so on. So in such patient, we need to elicit a detailed history, like is the child getting exposed to more number of kids, for example, in a creche or in a playgroup, because then these kids are exposed to various other kids carrying different viruses and they keep on getting infected. From the description, what has been mentioned, this looks like the child had short-lived illnesses lasting 3 or 4 days, was okay in between, and then again developed similar illnesses. So this is also very important. How was the child in between these episodes? Was he eating well? Was he otherwise active? And to consolidate our point, we can plot the child's growth trajectory on a growth chart over time and show the parents that the child, though he's getting repeated infections, is overall growing well, developing well, and his weight and height is as per expectation. So we also need to counsel these parents that all young children, for example, the typical preschool age group children, are expected to get around 6 to 8 upper respiratory infections in an year, and that is more or less a norm. So once they are aware of these facts, the parents become less or more understanding, let us say, that this is going to happen for the first few years of life, and then they would get better as they grow up, as the immunity also develops to these viral infections. So the most important thing is we need to give the patients, parents time. We need to understand their concerns. We need to find out why they are worried, and then try to give the proper explanation regarding why the child is getting repeated infections and how these infections are more or less likely to be innocuous rather than anything ominous.
Right, right. And Dr. Anil, do you have any other points to support what Dr. Sanjay said?
No, sir. Sir has mentioned all points. I think giving that extra 2-3 minutes to the patient, just talking to them, explaining them, telling that this is what the child is getting from the other children from the school or the play group, repeated infections, explaining them, and we tell them that the child is growing and so is the immunity of the child. There is nothing called a ready-made immunity or immune boosters, or none of these magic medicines are there. Even we would all fall pray for a new virus. If someone comes and gives us a new virus, like what happened with COVID-19, all of us will go down because there is no ready-made immunity. So I think spending more time and explaining them will help, sir.
Yeah, very good. And as you said, COVID can be, used as a good hook to start the discussion. You can say that the child, all children were indoor and they never developed any immunity. And now these children are growing in the open world where they are developing the immunity. And I remember you telling me, earlier that you can consider these cold and cough episodes as the members of the family. Those are going on along as the child is growing. They are also bound to be behaving like members of the family. So till the child is growing well, there is nothing to worry about. It's important. And one important point is, our colleagues also should take out a little time to explain. Otherwise, many times some medicines are given reflexly without much of a thought process going on inside. So these 1 or 2 extra minutes are very important. As it is, I always feel that we charge our consultation charges, and many times we are rather being paid not for prescribing medicines, but for not prescribing medicines also. For example, antibiotics. We are paid for not prescribing antibiotics, so that we have some responsibility towards society of avoiding antibiotic abuse also. So these are some important points. And then, of course, we should know as to how to identify whether this is viral or bacterial. So if there is onset with cold and sneezing, and the child is otherwise okay, playful, then we can suspect that it's likely to be a virus like rhinovirus, which usually involves only the upper airway and doesn't go down through the trachea to the bronchi and then to the lungs, doesn't produce pneumonias. And then, of course, adenoviruses, they present a bit differently. And sometimes they may produce pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, or hemorrhagic cystitis. Bronchiolitis is typically because of RSV, though other viruses also can produce bronchiolitis. The commonest is RSV, and it occurs under the age of 2 years, particularly under the age of 1 year. And some bacteria, they have their signature presentation, like the group A beta hemolytic streptococcus will affect the throat, produce follicular tonsillitis and tender cervical nodes. Pneumococci, Streptococcus pneumoniae will produce a picture like pneumonia, where you may get fever with grunting, and staph will be, presenting with in a more toxic manner. There will be rapid progression from pneumonias and down to the fluids and pus and so on. Mycoplasma will usually affect little relatively older children and will present predominantly with cough. So knowledge about the viral and the bacterial and the presentations, this I call it as educated guess. Once you know, then you can guess what it is, and then you can base your treatment decisions on these. Dr. Anil, I would like you to analyze one case which presented to us. He was a 4-year-old child with fever, cough. Fever was of high grade, and the fever was not settling with oral medicines. And on admission, the child had tachypnea and needed oxygen support. This was the X-ray which was showing some lesions on the right side. The hemoglobin was 11.6, the total count 1620, platelets were 132,000. The liver functions were mildly deranged, and the throat swab was positive for H3 and 2. So we thought that it is influenza with low WBC count and low platelets. Maybe for the benefit of our listeners, I would like you to analyze and just let us know the approach so that some of these common cases our colleagues can approach in a rational way.
Yes, sir. Exactly. I think the way you're describing, I have a patient exactly who presented like this and who is fit enough to go home tomorrow. So this child who came to us, around 3 to 4 year old child with high fever, cough, cold, and all this for 5 days. And child was not settling. Child was admitted at an outside hospital where the child was managed as a viral illness. And the child was, in fact, the parents got discharged from there and came to us on day 4, day 5 because the fever was not settling and it was a very high grade fever. And we had a similar X-ray, but it was on the along the diaphragm where the silhouette sign was positive. The differentiation of diaphragm could not be made out from the abdomen. So very subtle pneumonia probably was missed by the treating doctor there outside. So when we looked at this child, so when someone is so sick, even on day 4, day 5, we think probably bacterial infection also may be there. So we started the child on IV antibiotics pending the blood cultures. And we know that the season of flu is just round the corner. It's still happening, probably tail end of the flu season here in Bangalore. We went ahead and started this child on Oseltamivir also. And the counts were very, very similar to this. Platelets were low, platelets around the same thing. 132 is what exactly what we had. But unfortunately for the doctor who was treating outside, the dengue card test had come flagged positive for a IgM dengue, and they were counseled that it's a dengue fever and was being treated. So even on day 4, day 5, the fever was not abating. That's when the patients came to us. We knew that dengue doesn't come with a cold cough, so we knew it was a flu-related illness. We had started on oseltamivir. And the transaminases also were mildly elevated, which settled down. And lucky for us, our dengue ELISA was negative, and our flu panel was flagging positive for influenza B kind of virus. I think this situation, we confidently we stopped the IV antibiotic, just continued with the oseltamivir, and the child is fit enough to go home tomorrow. I think, sir, like whatever presentation we have you have put, I could see that happening live in our patient over the last 3 to 4 days. It was happening live, and thankfully the child has recovered and will be discharged tomorrow.
I'm glad that you have analyzed it perfectly. And reason for these low WBC and the low platelet count usually is the bone marrow suppression by these viruses. There were other cases which presented with H3N2 like presentation, and few cases had CRP on the higher side, and there was, of course, one child who presented with cough and cold, but the WBC count was high, the CRP was quite high, and the child continued to have high fever, and the nasopharyngeal swab showed adenovirus positivity. So this was the child who presented exactly on the same lines, but the investigations and the throat swab gave us the proper diagnosis. We, in fact, saw some cases coming with lobar pneumonias and never responded to ceftriaxone, continued to be in the hospital for almost 2 weeks, and later on they were diagnosed to have adenovirus. There is another child, Dr. Sanjay, a 5-year-old girl with high fever for 5 days, cough and cold, sick. An examination has mild wheeze, but there are no crepitations. So the question for our colleagues is whether I start antibiotics and let us first analyze, and then I will tell you as to what was done for this child. So can you just analyze this case?
Yes, sir. So this girl, 5-year-old girl, has high fever for 5 days. Now, if you're getting high fever for a longer duration, there is some thought process whether this is a bacterial infection as such. But she had cough and cold. So presence of cold usually tells us it is more likely to be a viral infection. So we should also try to get a history of anyone else in the family is also having some upper respiratory symptoms, either before this girl or after this girl got the symptoms. However, this child looked sick as per the description which has been mentioned, and the lower respiratory tract was also involved to some extent. with few mild Vs. However, there are no crests. So in such a situation, though the probability of viral infection still looks a little more, still I would probably err on the side of caution and start antibiotic as well for this child, along with the antiviral as well.
Great. So this child was put on amoxiclav. The WBC count was 2800 and CRP was 34.7. This child was put on oseltamivir and nasopharyngeal swab was sent, but it showed rhinovirus positivity. As you said earlier, already this child is on amoxiclav and in addition on oseltamivir. Now there are the treating physician has quite a few problems in the mind as to I thought of influenza, but the swab is showing rhinovirus. Now, what do I do? Whether I should continue with this amoxiclav that I have started. So all these questions are always going to be there. Now, in connection with this case, let us discuss one important issue related to the sensitivity of these tests, particularly the throat swab report. So, what is your opinion about the sensitivity and what are the treatment decisions based on these reports?
So actually, the tests which are in vogue in these days, that is the PCR-based tests, either the singleplex or the multiplex tests, they are quite good. They have an excellent sensitivity. And usually there are two types of tests which are used for the respiratory infections. One is the upper respiratory panel, which detects most of the viral illnesses. And if the child has a lower respiratory infection like a pneumonia, then there's a different lower respiratory panel. So for this influenza RSV type of test, the upper respiratory panel, which is done on a nasopharyngeal and a oropharyngeal swab, is the best test available. As I said, the sensitivity is quite good. So if you take the sample properly, and this is very important, that the sample has to be taken properly by a person who is aware what he is doing. So deep nasopharyngeal and an oropharyngeal sample needs to be taken, and then that needs to be processed after transporting it in the viral transport medium. Now, in this particular test or in this particular case, if you look at the report which you have gotten, so rhinovirus, as we discussed earlier in this today's talk, usually is limited to the nose mainly with more of a rhinitis. So this child's picture is definitely not matching to a typical rhinovirus type of illness. So I would still look at the epidemiological situation about the number of cases which are going on in the environment or in the surroundings, and definitely continue my oseltamivir for a complete 5-day course, though the report of the test is showing something else. As far as the antibiotic is concerned, the lab investigations are not very favorably suggesting a bacterial infections. I would think of stopping an antibiotic and monitoring the child basically only on oseltamivir and see how the child does. And that would be my plan of action for this child.
So many times the decisions have to be taken depending on the clinical picture of the child and day-to-day progress of the illness. Dr. Anil, this was a 7-year-old daughter of a couple from the IT sector, and this child had high fever for 3 days. The child had throat irritation, and she had examination in the school after 2 days, and throat was showing only mild congestion. The child was put on paracetamol, and as flu and adenoviral cases were rampant in the atmosphere and the parents were educated, they had quite a few queries whether one should go ahead with investigations, whether one should go ahead with the throat swab, whether one should put on empiric oseltamivir. So how would you approach such a situation?
Yes, sir. In our day-to-day practice, there are multiple times that we are tested, pressurized also, multiple factors. Here, one being that it's a IT sector parents who wants to ask us more questions and wants more proof, all these things. Child is running a high fever. We ourselves may be coming under pressure, which looking at the high fever. Second, the other thing is that there's an exam which is coming up after 3 days. All these factors are like pressurizing the doctor to do something more. I think in such situations, I think we stick to the basics. We still go back to our syndromic diagnosis of influenza-like illness or acute febrile respiratory illness, categorize into. This is where the categorization comes into play. We can always show the father or the parent telling that these are all the symptoms which are listed in category A and your child is coming in category A. As long as the child is stable, we will continue to observe. We will explain him all the red flag signs and we tell them most of the viral illnesses are self-limiting. So we will wait for the next 24, 48 hours. We'll see how things go and then we will take it forward. I think that spending that couple of extra minutes and showing them is good enough. Just symptomatic supportive care for category A should do, sir, in this situation.
Right. So once you explain and tell them about the categorization, hopefully they would understand the significance of the categorization and the management, which depends on the categorization. Right. This was another child, Dr. Sanjay, a 3-year-old boy, came for cough for a week, high fever, crepitations. The child was put on co-amoxiclav. The child was admitted for persistent fever. He was put on intravenous amoxiclav. The counts and the CRP were almost normal, but the throat swab showed influenza A, and that's why oseltamivir was added. Again, a typical confusing scenario where on the clinical grounds we have put the child on antibiotics, but the report shows influenza, that's why you have to add oseltamivir. Now, in these situations, whether would one stop antibiotic or whether you would continue the antibiotic along with antivirals. So, how would you approach such cases?
So if you look at the patient's condition as well as the lab reports, in general, though the child has a few crepitations and high fevers for 3 days, the lab reports are not at all suggestive of any bacterial infections. And on top of that, our flu, the swab has come positive for influenza A. Now, this is a very important thing because these tests are quite reliable in a given scenario. And with this test report with us, I would probably think in terms of stopping the intravenous antibiotics because de-escalation is the way to go forward, especially if you have a clear diagnosis in front of you. Having said that, I would not just stop the antibiotic and leave the child. I would, of course, follow up the child because we do know that occasionally the cases of influenza also tend to get like super infected with bacteria. So we would keep a close watch on this child, keep continuing on Oseltamivir, and if the child is showing a good recovery, we would stop at that. If at all the child shows any signs of deterioration or increasing complications, then we would think of a bacterial infection and maybe start the augmentin again.
Okay. So this is a part of antibiotic stewardship. And then, as you said rightly, if the PCR comes positive for influenza, then either you stop the antibiotic or at least do not escalate it further and watch the child and the clinical progression. There have been a few cases wherein we had some neurological problems related to influenza, and this was a child, 1-year-old child with fever, cough, cold, and presented with status epilepticus, and the nasopharyngeal swab showed H3N2. MRI showed non-specific encephalitis changes. The CSF was normal, and this was labeled as influenza encephalitis. So, Dr. Anil, I would just like you to tell us a bit more about neurological complications of influenza.
Yes, sir. This season, I think we saw more and more cases who got admitted to our HTO or the ICU. Need not be respiratory. Some of them had neurological complications or they were admitted mainly for neurological issues also. See, this viral respiratory illness of influenza brings about a sudden high-grade fever. Children become like quite febrile. So we had lots of small babies who got admitted for incidents of first episode or multiple episodes of febrile seizure. These were one category who required very minimal care and they got better. We had few more little older children and adolescents because of high-grade fever. They became delirious. They were admitted for febrile delirium, required little more supportive care, and even they got better. And we had few patients who came to us with multiple episodes of seizure with no regaining sensorium in between. These are the febrile encephalopathy kind of patient also we did see. When we evaluated these patients, what we saw is one of them had a feature of ANEC or acute necrotizing encephalopathy also, where the deep nuclei in the brain, like the thalamus, had these deep lesions with a central necrosis also. And the CSF wouldn't show any cellular response because this was more of a immune mediated kind of a response because of the release of IL-6 and the IL-1. This is more like a cytokine storm kind of a presentation where the brain took the hit secondary to the immune activation because of the virus. So here we can't demonstrate it, the virus directly in the CSF. The virus has to be demonstrated through the nasopharyngeal swab only, but they can have devastating CNS manifestations in such children. Also, we did see children presenting to us with GBS and few children who presented more like a close mimicker of GBS because of the peripheral neuropathy that they had. And aseptic meningitis, we did see a couple of patients.
It's very important. And this particular encephalopathy or encephalitis is a rising concern. And as I was discussing with you earlier about this CDC review, which was published early this year, that was a review of cases between 2010 and 2025, so almost a 15 years survey. And about 9% of the pediatric flu deaths had that IAE, that is influenza associated encephalopathy. And specifically in the year 2024-25 season, among the pediatric deaths, there were reports of this acute necrotizing encephalopathy. As we all know, even the dengue and the flu, both these acute necrotizing encephalitis have a very bad prognosis, and mortality is very high. And what was more important is that according to this data, many children with this IAE, that is influenza associated encephalopathy, and that acute necrotizing encephalitis, who died were previously healthy. They did not have any basic problem. And the vaccination rates in this group were very low. So it's another reason that our colleagues must know that they must vaccinate whatever, benefit it has and whatever efficacy of these vaccines it is, they are really going to help the child. Okay. There were quite a few cases who came with influenza along with RSV, and we had to treat these children for both these infections in the usual way. Dr. Sanjay, in addition to otitis media and pneumonia, which we discussed as complications, respiratory complications of flu, do you have anything else which you could add to the respiratory complications of influenza?
Right. So ARDS was something which is a known complication of influenza, and that is a very devastating thing because the child has a lot of morbidity, requires very intensive management, and most of the times they do recover, but it is a very long drawn course. Of course, children who are already known cases of asthma, their asthma tends to get exacerbated because of these viral infections like influenza, and we did see several of these patients who came with an acute exacerbation of asthma because of influenza infection. And a couple of them also landed up into respiratory failure because of the severity of the influenza-induced pneumonia. As far as the crew type of presentation is concerned, I remember one case who presented with stridor and turned out to be influenza. So though we say stridor or crew is commonly because of para-influenza, we do get influenza causing this presentation occasionally.
Okay. Okay. And of course, there have been cases with toxic shock syndrome, rarely myocarditis. Myositis is another complication in boys in the age group of 6 to 9 years. And this is more with influenza B, where there is involvement of bilateral gastrocnemius and soleus muscles. And severe bilateral calf muscle pain and inability to walk is the presentation. During the residency days, all of us have witnessed cases of Rye syndrome, where exposure to salicylates in children with influenza B would precipitate some picture akin to liver cell failure. There are a few quick questions for both of you. So, Dr. Anil, if the elder sibling of an 8-month-old child is admitted for influenza A with LRTI, and the younger one, the 8-month-old child, now develops fever, shall we start oseltamivir for the younger child?
Yes, sir. I think this is a scenario of starting whether to start a prophylaxis or a treatment. In an 8-month child who already develops fever, I think we should go ahead and start the child on full treatment dose, especially because this child is coming in the high risk category. Anybody who is less than 2 years comes in high risk zone, high risk uh, feature is there. So I think we should go ahead and start even without waiting for the swab or even without doing a swab. I think it's worthwhile to go ahead and start this child on treatment dose of oseltamivir.
Right. Dr. Sanjay, in case if a child is not accepting the oral medicines, is there any alternative therapy?
So unfortunately, no. The only therapy which is available for influenza is oseltamivir, and the oseltamivir can only be given in the oral route. So there is no other option. We have to give orally. Fortunately, this drug oseltamivir is very well tolerated, and even small kids take the syrup very easily. So that is the only option we have.
Dr. Anil, what is your opinion about chemoprophylaxis to the household contacts?
Yes, sir. Chemoprophylaxis is indicated for the high risk contacts. Like for anybody, like a grandparent who is aging more than 65 years, they have other comorbidities like a cardiac condition, they have a chronic lung condition like a COPD, asthma, or they're on immunosuppressed for whatever reason, may it be chemotherapy or steroids for any long-term medical conditions. These are all the high-risk contacts which needs to be treated with chemoprophylaxis.
Right. And Dr. Sanjay, what is your opinion about para-influenza viruses being treated with oseltamivir? Will oseltamivir work on para-influenza?
No, the simple answer is no. Oseltamivir is only for influenza infections, no role in virus infections.
Right. So that was only to make the thing a bit clear. So we have learned a lot about influenza and early therapy with oseltamivir and the questions related to the antibiotic therapy, antiviral therapy, nasopharyngeal swabs, and so on and so forth. What we have learned is that influenza is a fast and a furious virus. It has a abrupt onset, high transmissibility, rapid progression, and progression even to complications like ARDS. So we have to be very, very alert and we have to start oseltamivir early. We should also be aware of preventive measures like sanitization, mask, and social distancing, following the cough etiquettes like coughing in the elbow, so that cough in the hands would probably transmit the viruses to the fomites like the tables, the laptops, the staircases, and so on and so forth, and the spread would be more. So there are some cough etiquettes and following some rules, sutras related to the use of the hand, like frequent hand washing, particularly after examination of every child. One should wash the hands, avoid handshake, use the handkerchief, keep other people at a hand's distance, and also avoid touching of the hands for all the obvious reasons that we have discussed till now. Preventive measures like flu vaccine are extremely important. And whenever you greet anyone and say happy birthday to you, also tell him to take a shot of flu. So you should also say happy birthday to flu, because the viruses, they change their structure, so the composition of the vaccine changes every year, and that's why you have to take the vaccine. The immunity given by the vaccine in 2025 wanes over next 6 to 9 months, and at the end of 1 year, it has come down to a very, very low level. And that's another reason as to why you must take the vaccine again next year. Even though the strains don't change, you have to take the vaccine next year again. Remember that. And not only you, but also see that your staff members, the receptionists, the ayah, the ward boys, and your family members, all of them, they receive the vaccine, because when you come back home, our family members are also equally exposed from your contacts, and that's why you have to be very, very, very careful. Remember that there are some implications of flu in relation to the pediatric practice. So one of them obviously is this vaccine protection. Second is obviously this early antiviral therapy. Then awareness about the neurological complications, which we discussed. And you have to also report these cases that you come across in the practice. So that is some collaboration with the surveillance, and also education of parents, because many parents are under the impression that, oh, flu, oh, it's a very simple illness. It's something like a bad cold. But then tell them that it's not so simple. The recent high severity and the risk of serious complications make prevention and early use of oseltamivir very, very important. So with that, I thank all the listeners and my panelists, Dr. Anil and Dr. Sanjay and Hetero Pharma, for giving us an opportunity to explain a lot about this illness and oseltamivir. And let us hope that we continue to bid farewell and greet others by saying namaste and avoiding shake hands. Thank you very much.
Thank you, sir. Thank you.
Thank you. Thanks, Dr. Joe. Thanks, Dr. Anil. Thanks, Dr. Sanjay. Thanks all the doctor who took time from their schedule and attended these sessions. Thanks marketing and sales team of Hitro for coordinating. Thanks Bhuvan for IT support. Thank you. Thanks all of you.